I want you to know what a terrific privilege it is to have the opportunity to lead this institution at this incredible moment. All of you represent the lifeblood of the institution. There's lots of terrific things that go on here. There's beautiful buildings. There's really a great spirit that exists on the campus, but the students are the lifeblood of our institution, and we're very happy that you are here. You're an extremely selective group of people. If you could see the list of people that unfortunately we had to say couldn't come in the class, you'd be even more impressed because the qualifications that you bring to the table are outstanding. And so for a paper boy from Walpole to have the chance to actually lead this great institution at this time is really pretty terrific, and I want you to know that. The room was still. Only a constant and steady beep broke the silence. In the corner, a light shone dimly upward. Chairs surrounded the bed, the head of which was raised. Hands reached out in tender contact. There were weary smiles of sympathy and resignation. And slowly the door opened. The attending physician, fellows, residents, and medical students respectfully approached the bedside. They exchanged a few words. The attending accepted the patient's outstretched hand. Now, physicians live this moment thousands of times during our careers. Nevertheless, each encounter with a patient is unique and profound, because in each instance, we as physicians accept an awesome responsibility to assure the patient's human dignity. As such, we enter into an inimitable covenant with our patients. We agree to do what we can to care for them and about them. Respect pervades these relationships even after we've stopped counting the number of them. So we welcome you to this day of privilege, of sharing these moments with those who will become your patients. We greet you as fellow professionals, and in so doing, we reaffirm our pledge, the pledge we took to teach those who will come after us in this noble cause of medicine. And I want you to know truly it's a great pleasure for me to be with you on the beginning of your medical education, which will become a day of commitment and symbolism, which so vividly reminds me of my own beginnings in medicine. I know this is going to be difficult for you to believe. It's definitely difficult for me to believe that it was 32 years ago that I actually sat in the last row of the auditorium at Tufts Medical School. It was a very low-ceiling, antiquated lecture hall at 135 Harrison Avenue. It was a shirt factory in its day. So those of you who'd interviewed at Tufts, you know what I mean. But I got to tell you, that was a moment. It was an incredible moment to be sitting where you are. You know what? It all paid off. I studied at a rickety green table in my bedroom while I was getting ready to go to medical school. I remember a Time magazine article on a dissected rheumatoid hand that had been the subject of my second grade show and tell project. I can still see it. I wrote with like silver ink on black paper, and I had these pictures of these rheumatoid hands. I was in love with my second grade teacher, Mrs. Lind. She was actually Miss Kerr, but she became Mrs. Lind. And I wanted to do such a good project so that she would like me. My youthful interest was really not that casual, however. I was a pretty sick kid. I had spent weeks in the hospital suffering from pneumonia. No idea what it was in retrospect as a doctor. But there were no length of stay restrictions in those days. And I can vividly remember lying in a bed of an unair-conditioned room in Norwood Hospital and hearing the call over the intercom, Dr. Collins, Dr. Dennis Collins. And I would sit there and I would wonder, could I be a Dr. Collins one day? Now, Dr. Collins was my father's cousin, and he was a Tufts graduate. In every way, he was a Rockwellian general practitioner who would care for our family. He was pretty rough and gruff, I've got to tell you. He gave me chloromycetin when I had a fever and calamine lotion when I had poison ivy. And when you'd go to his office, you'd sit in the waiting room, and he would open the door and peek through the crack near the hinge and say, "Next." And I can remember going in to see him as the next patient. I have to be honest with you, I was in awe of this man. He, Dr. Joseph Murphy, Dr. Jim Collins, my uncle, Dr. Dennis Collins, the son of the Dr. Collins, Dr. Jim Collins, my cousin, all preceded me at Tufts. And these connections to our school continued to be a blessing and a burden for me, as evidenced at a reception the night before my classes began. I was sought after, this is where this dream comes from last night, I was sought out by this somewhat zealous staffer from the development office. And she came up to me and said, "So you're a Michael Collins. You have no idea what it took me to get you into here." Now, I have to be honest with you, to this day, I prefer to believe that she overstated her efforts just a little bit. But mostly I want you to know this because this lineage in medicine for me has meant and still means an enormous amount to my family. From that back row in Patent B, I was well aware that I was about to embark on a marvelous journey. And in fact, it began immediately. As my classmates and I received welcome after welcome, as you will over the next few days, from those who had positions like ours in leadership in the school, all of us were distracted by some mysterious words that were written on the chalkboard behind us, all during that session. And the words were ant thigh, PG page 68 to 73. Now I wondered if perhaps somebody had forgotten to clean off the board before the first meeting of our class. But soon enough it was clear. After the last greeting had been given, the director of the anatomy section of our curriculum, Dr. Jim Moorhead, walked to the center riser in front of all of us, took the microphone in his hand, and he told us to review pages 68 through 73 in Grant's dissector before we returned to school the next morning. We would be dissecting the anterior thigh as our first assignment in gross anatomy. So medical school had begun. Now, only with that 30-plus years perspective can I fully realize the privilege that was about to be accorded to us and will be accorded to you. Nowhere else in society can a person dissect a body without going directly to jail. Yet in medical school, through the generosity of our best teachers, our patients, we learn anatomy. This is where we first encounter the physician-patient covenant. A patient donated her body. She donated that body to science, to educate future doctors. She did so willingly and with the expectation that they'd treat her body with reverence and would be conscientious in their studies so that future patients would benefit from that knowledge we gained. Soon you're going to experience the power of that trust. You'll enter the anatomy lab for the first time, and it will be as if you have entered a sacred place. There'll be some anxiety and apprehension, but the anatomical structures in the anterior thigh will not overwhelm you, and neither will the experience. Still, I'm going to tell you these moments will be intense. Exercise the care and compassion of Galen. Study with the intensity of Osler. Consult your teachers and peers with the wisdom of Cecil, and always hold the hand of your cadaver with esteem. I shall forever remember the day when we dissected the hand of our cadaver. Now, students were partnered in those days, and there were actually 5 hands, alternatively supporting and releasing each other. 25 fingers intertwined at any moment. It was difficult sometimes to discern in which hand or finger we were supposed to dissect. And it was humbling as well as slightly disquieting to recognize that any one of them could have been mine. If you think about it for a minute, my hand, Dave Cutler's hand, and our cadaver's hands, all intertwined. Hands in hands. I understood then that there was much more involved in the action than identifying tendons and muscles and bones and finding insertions. There was the covenant. There comes a time when a person entrusts his or her future to someone else's hands. And then there was the epiphany. Sometimes those hands would be mine. Now, perhaps you'll have a similar experience. For certain, you're going to be wearing your white coat much sooner than I did, because in the 70s, we didn't receive our white coats until the second half of our second year of our education. As M81 T2s, what we were called, we entered the physical diagnosis lottery, and we went to our selected practice sites where we would learn how to perform physical exams. There was really no pageantry of the white coat ceremony that you'll all experience in just a few weeks. We simply showed up on the second Tuesday afternoon of January in 1979. We put on the white coat and headed in to find our preceptors. Now, I must admit, it was quite a sight. Some of my classmates looked like waiters in fancy or perhaps not so fancy restaurants. They had buttoned all 3 buttons of their short white coats, carried their little black bags they had purchased at spas a few weeks earlier, and marched forward with a determination to their hospital or their physician's offices. Most of us put our stethoscopes in our ears backwards. We couldn't figure out how to turn on the ophthalmoscope without shining it in our own eyes. And we inserted throat sticks so far into the oral cavity that we nearly broke the teeth of our partners as we sort of triggered their gag reflexes with sharp and sudden bites of the stick. Now, once we find out how to use the stethoscopes, we auscultated and palpated each other's lungs. We listened to each other's heart sounds. We thought we were pretty well versed in this art by now, as we had been practicing on every member of our family over the holidays. Now, my preceptor would later become a close colleague, and he listened to my heart. And he had my partner do the same thing. And then he proceeded to tell me that he had heard a murmur and an opening snap. Now, I looked at him with a bit of incredulity, because Dr. Collins had never told me that I had a murmur or an opening snap. But with surety, I was being told by my preceptor that I had mitral valve prolapse, though he stated as confidently that I didn't have anything to worry about. It was pretty easy for him to say, I can tell you. Now, being the consummate stoic, I shook off this diagnosis. I proceeded to palpate my partner's abdomen, nearly perforated his bowel as I was a bit flustered. And I pressed so hard on him because I was trying to find the pulsating abdominal aorta. The session concluded shortly thereafter. I put on my white coat. I marched bravely through the hospital corridors, got back on the 57 bus, and headed back to town. But when I got home, I was a wreck. What was mitral valve prolapse? It sure sounded pretty serious to me. I put my stethoscopes to my ears. I tried to hear this opening snap and this murmur, but I have to admit, whether it was S1, S2, S3, or S4 heart sounds we had learned in cardiology, never mind murmurs or an opening stack. This was beyond my appreciation right now, because I was in panic that I had heart disease. All night long, I was trying to study for my next day of classes. I stared at this red brick wall that was in front of me in my apartment in the South End, and I had chest pain. It was more like a pressure than a pain. It went up my neck. It went down my left arm. Nothing made it worse or better, and I was sure I needed a cardiac cath or nitroglycerin or something. And so that evening, I want you to know, I kept my exercise around the apartment to a minimum. By 6:30 the next morning, I was outside the office of Dr. Modestina Crisotiello, who was the head of our cardiology system course. Dr. Chris, as he was known, arrived shortly before 7 and asked me, "What the hell are you doing here?" So I told him this story. And I said that, you know, with my vast knowledge of cardiology, I was sure I needed a cardiac cath or something right away. So he took me into his examining room, and before long, I was assured that I had neither a murmur nor an opening snap, and that I could turn to class without cardiac rehab. And I felt pretty good about that. But what happened to me is known as medical student syndrome. Your white coats are not going to make you immune from this phenomenon. When you're studying neurology, every headache you have is going to be the sign of a brain tumor. When you're studying dermatology, every time you take a shower, you'll find a mole that you're sure is melanoma. When you're studying GI, every gas pain will represent an evolving bowel obstruction, or given your anxiety over pending exams, irritable bowel syndrome. But fear not, most common things are common, and I'm quite confident you're all going to graduate with a pretty clean bill of health. But at the time, I experienced this agonizing night. I learned some pretty important lessons, and those lessons have lasted to this day. Always be careful in explaining any findings to your patients. What may seem like nothing to you could mean the world to them. You must remember that the words you speak will be mulled over and over again in the minds of your patients and the members of their families. A patient encounter may become routine for you, but they're not routine for your patients. A visit to the doctor is the most important occurrence in a person's day, week, month, or year. So how could that occurrence ever be experienced as routine? And remember that your words are never simple and clear, even if you think they are. Their interpretation may be quite different from the reality. You must recognize that the caring really begins once you make the diagnosis and transmit that information to the patient. Now, I remember when my father died in 1975 of a brain tumor, that Dr. Collins, the younger, walked out into the hallway and said, "I want to tell you guys, your dad is dead. And I would hope the next time that we could do more." And for years, I wondered, what did he mean by that? Did we not do enough? Should we have done something else? Was there some other treatment he could have had? I think what he meant in retrospect was that my father had a devastating illness and that there really wasn't much that could be done. But if you have one memory of this lecture, when you tell a member of their family that their family member has died, remember that the words you say will be remembered by those people for the remainder of their lives. Now, in institutions, you're going to see that the length of the coat represents the seniority of the person wearing it. Senior attendings will have the longest coats. Residents will be a little shorter than ours. Medical students will have the shortest coats. A physician I respected as a consummate professional and a caring clinician and teacher always wore the medical student's length white coat because he believed, even as a full endowed professor of medicine, that he was a student forever. In some institutions, no physicians will wear white coats except to cover scrubs when they come out of the operating room. In those places, the clinicians are concerned that the white coat brings an air of superiority. In pediatricians and psychiatrists' office, you may never see a white coat because they're concerned for their patients' frailties. You're going to wear many white coats during your professional years. They'll symbolize your professionalism, the virtue of your medical calling, the trust your patients place in you, and your commitment in the recognition that it's a privilege to care for our patients, and not a privilege for our patients to be cared for by us. It's a privilege for us to care for our patients, not a privilege for our patients to be cared for by us. To wear a white coat means you've chosen to dedicate your lives to the needs of others. It means you've entered into a profession consisting of many professions: scientist, clinician, caregiver, counselor, consultant, administrator. To wear a white coat means you'll be uncompromising in your commitment to evidence-based care and to the standards of our profession. That you'll need to rely on sound judgment, and that you'll always need to make the needs of your patients foremost, especially when you face the reality that you derive your livelihood from caring for those who are in great need of your professional skills, a challenge that may bring some temptation or introduce complexities too great yet to imagine. To wear a white coat means that the wonders of fascination of science await you. In my third year of medical school and my pediatrics rotation, I saw almost 100 children with cherry red lips and desquamation of the palms of their hands and soles of their feet. In moments of media-induced panic, we learned on the morning news about children from cities and towns across the state with these findings who had developed cardiac abnormalities, and a few hours later, we were admitting these patients to the floating hospital. They had Kawasaki's disease. That was the diagnosis, and we were at the epicenter of diagnosis and treatment. To wear the white coat means you're going to need to be selflessly committed to lifelong learning. I graduated from medical school before HIV was discovered, before retrovirals were used in its wake, and before AIDS even had entered the world. But I remember keenly the first time I read about this unnamed disease afflicting immunocompromised men from San Francisco. If I had stopped my education then, what good would it have been to the first patient that I saw with HIV? Today we learn daily about new intricacies of the genome and the power of RNA. We study the potential of RNAi as a therapeutic agent, and we explore the potential of stem cells and hope that they may be able to help us unlock uncomplicated disease states. You know, drug discoveries challenge our bureaucracies. Monoclonal antibodies are effective in rabies. In fact, our colleagues are testing it this very day in the KEM hospital in Mumbai. You enter medicine at a time when antibiotics like chloromycetin are treatments of the past, and when diagnostic modalities, once common in practice, will be supplanted by digital images and computer-enhanced technologies. The economics of medicine will similarly challenge the practice of your generation. We know that too many people in America don't have sufficient health insurance coverage. We know today that there are millions of children who go uncovered every day, reducing their ability to be properly immunized and maximally screened to prevent illness. We know all about health insurance coverage and cost. We know the challenges of the Medicare Trust Fund. We know about the cost of drugs. Now, many people are daunted by diseases and poor health practices that challenge the world. And too many places on the earth don't have clean water. Too many children have communicable diseases, despite the fact that we have vaccines to prevent them. Too many people don't have the wherewithal to seek care, prevent illness, because of poverty or civil strife and poor infrastructure. We know that today, Ebola in Africa can travel to Worcester in 12 hours. And we look to you to help us to try to cure these diseases. You know, ours is a great profession. There are many challenges and conflicts, but they're eclipsed by the chances we have to promote the human dignities of our patients. Soon you're going to have the chance yourself to do just this, because you will be the doctor that enters that dimly lit patient's room. You'll hear the monitors and experience the concern of the loved ones. You'll be the physician in the white coat who approaches the bed. You'll have the privilege to receive the patient's confidences and to understand the complexities of their medical condition. You will be the one who extends your hand to them. Now today, you can only imagine what awaits you when you reach out. What will it be like to put your fingers through the fingers of a neonate who weighs just a few pounds, whose parents tremble at the thought that the love of their life may lose their life were it not for your expert care? What will it be like to take the hand of a high school hockey player whose season has been ended by a fracture to her forearm and who seeks your assurance that despite all of that, nevertheless, they will look beautiful in their prom dress tomorrow night? What will it be like to grasp the hands of parents while they hold the hand of their college student who clings to life in an emergency room stretcher, surrounded by the resuscitation team that brought them from the highway? What will it be like to hold the hand of the first patient you see with a breast cancer or a melanoma or a brain tumor, when you realize that you don't have enough hands to hold the hands of their spouse and children at the same time? What will it be like to hold the hand of a grandfather with senile dementia, a titan of business who's been struck down by this debilitating disease and who is afraid but calm when you're there? Well, what will it be like? I could tell you quite a bit about what it was like for me, having cared with the deepest of respect and gratitude for each of these patients during the years that I've had the privilege to practice medicine. Let me just say that each of these patients placed their hand in mine as I cared for and about them, and each instant represented the privilege of a lifetime. In just a few days, you're going to begin your preparation for these encounters. And when your white coat is placed upon you, you will hold the hand of someone who cares deeply about you, someone who will help you in the days and years ahead as you begin your journey in medicine. The hands that care for you this day will be in the hands you care for in the days ahead. I'm going to tell your parents this afternoon that the relationship that you have with them will change forever now that you are becoming a physician. Consider the enormity and the possibility of that privilege you have been given. And please, never forget it. Now, personally, I wonder quite frequently what it will be like to have my own hand held by someone in a white coat, someone like you. We may hold hands when a person who's dear to me is ill. It may be when I'm worried that my future is short, or when I can't remember my past. It may be when my hand is being held in the anatomy lab. In that case, and if it's you who holds my hand, please know that it's my hope that as you do so, you'll find it a privilege to care for me. And I want you to be assured in advance of my gratitude. Because when you first have that privilege, and you make that commitment to hold my hand, I want you to know what a privilege it was for me to be with you on your first day. Congratulations and welcome to UMass.